So Dominique Medaglio joins us today from Christiana, and Dominique's going to tell us a little bit about her research as a junior investigator at Christiana.
Good morning, everyone. It really is a pleasure to be with all this morning and share a little bit about my passion, my work. For those of you who do not know, I am a registered pharmacist who decided to stop practicing pharmacy probably after working one too many years in the retail setting. But I was very fortunate enough to get connected with my pharmacoeconomics professor, and she was the one who kind of steered me toward the light, that is health services research. And ever since I have been working at Christiana Care, specifically at the physical hospital location, I really have taken an interest in the behaviors that surround how people take their medications, especially in the immediate post-discharge setting. So the concept of medication adherence, we know that it's a pretty big issue. It's approximated that about half of all persons in the United States who are taking at least one chronic medication do not take it as they should, be it skipping pills, splitting pills, forgetting refills, just forgetting about the medication at all, any number of those behaviors. And for the past about 30 years, the literature that has surrounded medication adherence has primarily focused on the behaviors that happen at home after the patient has already made the first fill for that new medication. And there are a variety of reasons that there are a variety of methods that we use to measure those kinds of behaviors. However, it's been traditionally difficult to measure how often people actually take that first step, make that first fill at the pharmacy, mainly because you need two sources to come together that until recently are not often readily available to researchers. And that is, one, the actual prescription itself, and two, the data from the pharmacy or the insurance company that says that, yes, the first fill was actually made at the pharmacy. So this leads into my pilot project. I was very fortunate enough to be funded with a Year for CTR Pilot Award. And here, me and the team, we've decided to focus on a pretty common procedure that happens at our hospital, which are cardiovascular revascularization procedures. And these include PCI, percutaneous coronary intervention, and CABG, coronary artery bypass grafting. So after any of these procedures, it's really common to be prescribed a litany of new prescriptions, specifically cardiac prescriptions, especially if this is the first time that the patient has ever had to deal with this issue. And we were curious to see how often do these new discharge medications never get filled. And we define never fill as no evidence of a fill within 30 days after the prescription was written. Clinically, we're hoping that you're getting these medications in your body less than 30 days, but we use 30 days. It's a pretty common cushion within the primary non-adherence literature. So I will just say this up front. The pilot study, I learned a lot, not only because this was my first project where I was in the role of PI, but I learned a lot about persistence and patience and learning how to pivot when necessary to get the work done. So at the beginning, we were going to initially merge these claims data and the prescription data into an existing data set already built around PCI and CABG procedures. And we pretty quickly, after we had received the grant and pulled all the data, we realized that the dates were not overlapping. So the data that I had with prescription data barely overlapped with the data we were going to merge it with. So I had to make a quick pivot and change the dates, slightly change the reach of the project because we couldn't do nearly the amount of cool stuff that we were going to do with the currently available registry, but we were still able to come up with some pretty good findings given the team's flexibility. So to go a little bit more into the methods of the project, we looked at procedures that happen within a Christiana Care health system from 2015 through 2017. And when it comes to prescriptions, we really wanted to focus on the population that had the ability to go home and fill it for themselves. So we excluded patients who were going to a skilled nursing facility, patients who it was very clear that they did not have the capacity to take care of themselves, self-manage. When it comes to claims data, something that, again, another barrier that we found out very quickly that we had to pivot around was that just because you see a claim, that does not necessarily mean that the patient had continuous insurance coverage across the time of the data that you have. Unfortunately, for this project, we were not partnering with the insurance company who could very clearly tell us whether a patient had continuous coverage or not. So we had to make a few assumptions, and that included excluding patients who did not have claims really close to the date of the procedure that we were focusing on. So we define that as 120 days prior to their procedure up through to 30 days after the procedure. If there was no evidence of any fills whatsoever, we then made the assumption that those patients probably didn't have insurance coverage or they were not using their insurance at that time to fill any medications. So, and we'll get to this a little bit in the discussion because there are a little bit of concerns about how this may introduce a little bit of bias into our population. Finally, the major other exclusion criteria that we applied was the exclusion of any medication that is currently available over the counter or behind the counter. And for those of you who are not familiar with the behind the counter status, there are a handful of medications that you can get without a prescription, but you must go up to the pharmacy counter in order to get them. And probably the most well-known behind-the-counter medication is Sudafed, because there are federal and state restrictions as to how much Sudafed you can buy at any given time. So what we ended up doing is taking all of these claims that we had available through the electronic health record. Our electronic health record, fortunately, is part of the SureScripts network, which is the largest pharmacy claims aggregator in the United States. SureScripts has contracts with a variety of EHR systems, just about every large retail pharmacy chain you can think of. And they also partner with 7 of the top 10 pharmacy benefit managers. So while we're confident that we have a pretty good spread, it does not include absolutely every single patient in the United States. So that is a limitation there. But we, again, we're confident that if you're only including patients who are pretty active, actively filling prescriptions during the time of their procedure, we're probably going to leave out patients who were, 1, not even included in the SureScripts contracting network, and 2, patients, again, who were not using their insurance during that time. When it comes to measuring primary non-adherence, it really is looking at the difference of the date between the date that the prescription was written for through to the date that you see the first fill of that medication. We do realize that insurance barriers exist, including tiering. So while one type of blood pressure medication may be covered with your insurance, the one that your doctor wrote may not. So to allow for this drug switching, we did not punish you, per se, if you received a medication in the same medication class of the one that you were prescribed. So that hopefully covers the majority of the methods. Are there any questions out there? Because I know I've probably thrown a lot, especially if you're not familiar with the crazy world of pharmaceuticals. Awesome. All right. To get to the analysis, we had a pretty straightforward analysis plan. In addition to the pharmacy prescriptions and then the pharmacy fills, we also gathered information about the patient, some characteristics of their visit, such as their length of stay, and then included that time to the first fill and censored everything after 30 days. So what we ended up having across our time study period, we had, within Christiana Care, there were over 2,000 PCI and CABG visits, and about 1,200 of those patients had sufficient data for our study. Across those 1,200 patients, they were prescribed over 5,000 discharge medications, which were ultimately included in our analysis. So let's start off with the patient-level data first. Of the 1,200 patients who were discharged within our study time frame, 61% filled all of their discharge medications within 30 days, which means that the remaining 39% did not fill at least one of their discharge medications. And when you look still across those 1,200, almost 10%, so 116 of those patients, did not fill any of the discharge medications that they were given within 30 days. So once we conducted some multivariate analyses, we found two major characteristics as being strongly correlated with not filling your medications in a timely fashion. And those were the length of stay that you had. Specifically, if you stayed in the hospital for 4 days or longer, you were less likely to fill everything within 30 days. And also a discharge medication count. So how many medications were you handed at the time of discharge? If you were discharged with 4 or more medications, you were also less likely to fill everything in a timely fashion. And when it comes to the medication level data of those 5,200 medications that were prescribed, almost 20% of them were not filled within 30 days. And the top medications that were not filled in a timely fashion included narcotics, which was surprising. That was the highest category of medications that was not filled in 30 days. 20% of narcotics were not filled within 30 days. And coming up right behind it were statins or cholesterol medications at 19%, and then some of the diuretics for blood pressure commonly used were also coming in at 19% not being filled within 30 days. So all in all, the results were pretty interesting. We were pretty much expecting length of stay and number of discharge medications to be driving these kinds of behaviors. In other literature where they are looking at primary non-adherence, there aren't too many studies looking at primary non-adherence at the discharge setting, but in other settings, including outpatient clinics, the number of medications that you have, the more that you have, the less likely you are to see patients succeeding in self-management. And this can include things such as polypharmacy. These patients, they tend to be a little bit older if you have more medications, and it can be very, very confusing remembering what pill does what and when you should take it and how you should take it, etc. So in conclusion, the primary adherence behaviors at our hospitals, they're less than ideal for this population, especially after a procedure like PCI or CABG. You want to prevent things such as another clot reoccurring, which can lead to a quick readmission. And while I was happy to see that the anti-clot medications were not leading the pack when it comes to not being filled in 30 days, other very important cardiac medications such as low cholesterol meds, loop diuretic meds for blood pressure, they are still very important and are evidence-based for supporting cardiac health. So we do have a ways to go. I have submitted this work to the Journal of Hospital Pharmacy, where we're under review right now. And in our discussion, I really push here for the role of pharmacists in the discharge setting. At Christiana Care, we currently have a pharmacy discharge program that supports patients in getting the first 30 days of all of their discharge medications in their hand before they leave. And while this is a wonderful program, and many other hospitals and health systems have such support for patients to improve at least that primary adherence, we should also be taking steps beyond that. So, for example, cabbage is currently a bundle payment program, a volunteer, rather, bundle payment program with CMS, and they are now testing bundle payments instead of 30 days post-discharge. They're now looking at 90 days post-discharge, meaning that hospitals and health systems are now responsible for more of what is happening outside of their walls for longer periods of time. So while we're giving patients their first 30 days, we need to be very mindful. How successful are they maybe on day 31 or day 32? How are they doing at that time? So there's more work to be done in this space. I really do believe in the power of pharmacists. I really do think that we're underutilized often in the discharge space. But I was very happy to see that eventually we worked beyond our barriers, all of the different data issues, and came up with some very interesting results that we can continue to work upon now. So that's my spiel. Are there any questions?